Hi, good evening, everyone. Thank you for joining me for this important discussion again with Dr. Shankara Shetty from South Africa. Every time I talk with him, I learn something more, find it fascinating. I just love talking with Dr. Shetty. Now, for people who don't know him or haven't heard about him, I just want to give some clarification. There are a few people across the world who got innovative with COVID. And where he was in semi rural South Africa, limited resources, 45 minutes from the nearest hospital, he came up with a strategy to prevent every single one of his patients needing hospital attendance for oxygen. It was incredible. None of his patients died. Now, let me just point out that the scientific community just doesn't believe it. They go, it's not possible. They must have all died. People must have died. He's making it up. Well, the evidence is in the fact that because of stuff he'd said in the past, he was challenged in terms of his license. They took him to court on what he said about the COVID vaccine, but they did not dare touch the outcomes because they knew they were real. And so, with that in line, what we are doing today is continuing to discuss what he is seeing. Just remember, this is a very innovative clinician. I love to listen and reflect on what he's seeing. Let's see what we can learn. So, without any further ado, Shankara, how are you today?
Hi, Philip. I'm doing well. I'm doing well. Seeing a lot of new things, but yeah, I'm doing well.
Excellent. So we're not even going to bother with a big introduction today. We're just going to get straight into a clinical discussion. And for those people who are watching, what we're trying to do is we are trying to understand what is being seen now and try and see if there are strategies to identify groups that are affected, what can potentially be done. But important to note that depending on where you are in the world will determine what your doctor thinks. So you can't use this information to replace you seeing your doctor. You just have to hope your doctor is listening to Dr. Shetty. That's the only thing we can say. But let's start off with some basics, Shankara. In terms of what's going on in the background, are they still looking to take this issue to court about what you said about the COVID vaccines in the past? Don't necessarily mention it in case it gets censored, but what's going on in the background there?
Well, Philip, the case supposed to have proceeded in March this year, and of course, I've got some expert witnesses from around the world. The testimony was going to show the intentional nature of what's transpired in the pandemic. The case strangely got deferred to May next year, for what I think is still after the start of the next pandemic. So yeah, we're waiting to see what's going to be the outcome of that. A year from now, a lot will change. I'm suspicious they might have a little more to charge me with by that time. So yeah, let's see.
Yeah, so I think that one of the issues that I am interested in is because of the autoimmune research that I've been looking at, and the fact that we have had large swathes of the population who have been immune primed through vaccination and then get reinfections. So this is the bit that I don't think people understand. It's just purely about the fact that normally if you have had an infection, and it doesn't matter which infection that you have. So if somebody was, say, getting measles over and over again, I would expect them to have problems because the immune system had got to be affected by the recurrent episodes of the infection. So any infection that is triggering your immune system on multiple occasions is likely to drive abnormal, dysregulated immune responses. And so when we have a situation where you have populations that have been infected, had vaccination, had further infections, recurring infections, still circulating infections, further exposure with mild symptoms, I am expecting pathology to change. And within that framework, I've been looking at hospital admission statistics in the UK, trying to look for trends. I'm looking for what is increasing, what is decreasing, what could be the explanation, because it will then give us a clue to pathology. Because at the moment, it seems that the scientific community has gone and frozen in the headlights of the questions, and now they're not doing autopsies. We are literally having to guess this out. Why do you think it is so difficult to get people to focus on the fact that people are still sick?
I think, Philip, from what's transpired, there's been a lot of mistakes made. People don't want to admit that those mistakes were made. So, yeah, I think a lot of people were forced into vaccination. There was a false belief that it's going to assist us. And now to backtrack, yeah, if people find it difficult. So you find that there's a lot of conflation with vaccine injury, long COVID. We still got a circulating virus that's causing problems, and we've got to understand those problems. It presents differently in vaccinated and unvaccinated patients, and to try and understand those cohorts and how they present is vitally important in actually negating some of the pathology that we see. And with the repeated infections, if patients are not treated appropriately, there's a steady, constant deterioration in their overall health. And we got to be quick to, like I did with COVID, we got to be quick and aggressive in identifying what's happening and trying to negate it. Your immunity can't remain dysregulated for over a period of time. It's going to cause problems.
So let's get right to the heart of it then. What exactly, from a frontline point of view, what are you seeing now in South Africa with ongoing circulation of the virus and disease presentation at the front? Because this would be more in the primary care setting as to what you're seeing. What's going on?
Well, Philip, I have a large proportion of my patients that are unvaccinated, but we're still seeing circulating COVID infections. We know that the main pathology with this virus is twofold. One is that it can trigger in certain patients an immune dysregulation, and that immune dysregulation usually occurs after the initial viral infection. So I have to educate my patients as to their peculiar dysregulation presentations. So some patients will present with an acute exacerbation of sinusitis. Some will present with microvascular coagulopathy. Some will present with gut dysbiosis. And you find it's recurrent. If you treat them, you get them well quickly. But the next time they have a COVID infection, they're going to go down that same road. So if they recognize their typical symptoms of immune dysregulation, they can seek my help relatively quickly. So it's about educating patients about the immune dysregulation that follows the infection, recognizing it, and of course, appropriately treating it so that dysregulation doesn't persist for any length of time. Uh, as well, besides educating patients about their unique pathologies and how to recognize it, we're also seeing some unique things in that certain patients undergo a priming, pathogenic priming, where if they vaccinated, they present in the same way with the viral infection, but vaccinated patients tend to exhibit a sudden exacerbation of symptoms within 2 or 3 days of picking up the virus. Now, we've seen this in the initial tests with the vaccine, where in mice, they developed a very severe hypersensitivity kind of reaction once they were exposed to the virus after vaccination. And this can be easily misdiagnosed as other systemic issues like myocarditis, pneumonia, those kind of things. And it's vitally important to educate vaccinated patients if they have this, that it's actually a pathogenic priming and it requires a different modality to treat it and to suppress it. So I think a lot of it is educating the population as to what's going on. Uh, the methodology for treating it, Philip, is relatively simple.
But I want to
When they
pause you there before you go on, Shankar. I just want to pause you on something here. One of the things that I am observing is that the current presentation of symptoms, especially I think in the vaccinated cohort, is exceptionally mild. So they will not even remember that they had either exposure or infection. They just had a bit of fatigue or headache. And this is complicating the fact that, therefore, it is not part of the history And so the doctor is not aware unless they specifically look for it. What are your thoughts on that?
Absolutely correct, Philip. The viral infection with the repeated exposure, the viral infection tends to not be as aggressive as the initial exposure to the Omicron variants. And you find this can present as a mild sore throat that persists for half a day and goes by, really unnoticed. And a few days later, a week or so later, you start to notice other symptoms flaring up. And so there's a disconnect if you don't inquire appropriately. Patients don't recognize that it was a mild infection that actually triggered the dysregulation, and they present with that dysregulation, which in a lot of patients looks like a flu, a repeat of the sore throat, sinus inflammation, all those kind of things. But one thing that is lacking in that, there is no fever. Patients don't have an active fever. They present with body aches and pains and those kind of things, but there's no fever. And if you question back, you will notice that they had a slight infection, even if it was for a day, about a few days prior to this starting up. So that was uneventful, and it tends to be missed. As well, the gut dysbiosis. A lot of patients will present with gut symptoms without recognizing that I had a sore throat a week ago, and that subsided uneventfully. But they start to have gut symptoms, and those persistent gut symptoms also trigger the dysregulation of their immunity. So I guess with each patient, you got to individualize their treatment according to their symptoms and educate them about that, so that
You know,
if it occurs again, they're able to recognize it and get treatment quickly.
I've seen the pattern where someone has unusual symptoms. It doesn't make any sense when you hear the pattern of the symptoms and you think, okay, this doesn't add up. Did you have viral exposure? And usually they say no. And what I've learned now is that you look for, were they in an environment where they were potentially exposed? Did anyone else around them have symptoms? And the time lag is usually about sometimes, 1 to 3 weeks before they then start to present with unusual symptoms. And it is so hard to get them to make the connection between that exposure and the current presentation. So that is not always quick. What are your thoughts on that?
Philip, I think that boils down to the diversity of the dysregulation and the way it progresses, the speed of progression of the dysregulation. Some people present with a very severe dysregulation and recognize it immediately, a sudden exacerbation of certain symptoms. Others will have a very mild, slow progression of symptoms. So it might be a sinus inflammation that slowly progresses and then starts showing up as a neuropathy a few weeks later. That progresses even further and shows up with gut issues a few weeks after that. So yeah, I guess it's dependent on the progression of the immune dysregulation, the speed of that dysregulation, and I think the intensity of it. Those that are more intense will present relatively quickly. Those that are having mild dysregulation, the symptoms slowly come on. But they all come down to the same fact. It's an immune dysregulation that's persistent. And of course, resetting it gives them very quick symptomatic relief.
There was a paper that was published, I'd spoken about it some time ago, where when they were doing breast cancer screening and looking at the lymph nodes, they found that 20% of those who had, I think, the Pfizer mRNA vaccine had lymph node inflammation up to 3 months. And I think all the way down to almost 6 months after they were vaccinated. Now, I suspect that there are different cohorts even within the vaccinated groups, meaning that there are a lot of people who are absolutely fine. They don't have any problems.
Yeah.
The people who I'm worried about are the people who have negative responses after they have been vaccinated. They feeling unwell, they fever, they having to miss days of work. Those seem to be the patients that are most likely, most at risk for the immune priming on re-exposure. Thoughts on that?
Yeah, Philip, if you look at the vaccinated and how they responded to the vaccine itself, you got three different groups. You got those who had a very acute reaction to the vaccine, and that immune dysregulation would present with anything from the severe anaphylaxis, which is what we saw people having severe reactions and within a day or two of having the vaccine demised or had very severe complications from it very early on. Yes, if they were treated well, that subsided. And of course, if not treated correctly, you save their lives, but they persisted with this immune dysregulation. The dangerous cohort, you got on the other spectrum, you got those who had no reaction at all. And they are, I think, relatively safe. They didn't have any real problems with the vaccine. But that intermediate group that had mild symptoms, that were persistent for a prolonged period of time, that didn't get to medical attention, didn't get recognized, didn't get treatment for it, have their immunity restored in a reasonable space of time, are the ones that will present with problems. If your immunity gets dysregulated by a pathogen, an allergen, and you quickly have it restored, then it resets itself back to its original settings. And of course, exposure and things like that are a different scenario. But if you have that continuous immune dysregulation, it will lead to an immune reconstitution. And once you get, and that takes a few months or a year for that to occur. Once you get the immune reconstitution, your immunity resets itself completely differently from the way it was built up from childhood. So the hand comes off the cancers, the hand comes off the immune issues and regulation of immune issues. The hand comes off the seeking for pathogens and treat and infections. So once your immunity reconstitutes, the guards left the door. And so you see a sudden surge in cancers, you see a sudden surge in autoimmune conditions, and that depends on phenotype. So autoimmunity can affect the entire body, even your heart. You will also see an emergence of, because of immune suppression, immune exhaustion, you will start to see immune HIV like symptoms, immunodeficiency like symptoms. So, opportunistic infections, all those kind of things will flare. But that takes a while for it to show up. So, it's that intermediate group that sit with long term dysregulation that tend to go into that kind of immune reconstitution.
Yeah, I wanted to capture something since you said it, and before I forget it. You mentioned HIV. What are you seeing with the patients, your patients that have HIV? What's going on with them?
Well, there's two things that I noticed, Philip. One, with my HIV patients, when they pick up the virus, these current circulating coronavirus, they don't seem to have very severe symptoms. Uh, Vaccinated is slightly different because they tend to have disruption of the immune system. But in the unvaccinated HIV patients that I have, they don't have severe symptoms. I don't see them progress into long COVID, and very few of them have all the issues with immune reconstitution. Look, I have thousands of HIV patients that are very well managed with very well suppressed viral loads, high CD4 counts, and I haven't seen real problems in them. So they're a cohort that needs to be looked at closely. They're not having the problems others are having. Look, in the setting that I have, a majority of my HIV patients are of black ethnicity. And I've noticed as well that amongst my black patients, I don't have many long COVID cases. We know that the virus, the variants of the virus initially had ethnic propensity. I did speak about that. And I think Robert Kennedy got in a bit of trouble mentioning that certain groups were spared. But we can't disregard that there's an ethnic propensity to the virus itself, and that's what I'm actually seeing. That patients on antiretrovirals do a lot better. So I think that's something to get looked into. Whether it's the high CD4 counts in those patients that actually help them keep them healthy, whether they don't trigger immune dysregulation as easily. There's something going on with that cohort of patients.
Yeah, this is important stuff, and this is what I am worried about. I'm worried about the fact that these nuggets of information that should cause us to actually think carefully, what could be going on. Because suddenly now, if you think about it from HIV, if you have a situation where the immune system, even though the CD4 counts are normal, they still probably have some degree of immune suppression. If they therefore don't get the chronic symptoms, it really does point to the fact that the immune dysregulation, specifically around the the T cells and probably monocytes, are the main driver of disease. And if we don't look, and if we don't try and study, and if we don't observe, these will not be picked up. There's almost an inertia now in the scientific, medical and scientific community. They want COVID behind them, and they're not interested in looking anymore. What do you think?
I think that's the reason, Philip. A lot of patients are not getting treatment that's effective. A lot of doctors are scratching their head trying to figure out what's going on. A lot of the blood tests coming back show no pathology. Remember, initially, when you have an immune dysregulation, you pick it up in your blood tests with raised interleukin levels, probably D dimers, CRP. But if you leave that immunity dysregulated for a prolonged period, the body tends to reset itself and those markers return to normal. But then you're going to miss it. A lot of doctors have been trained to seek diagnosis in blood testing or in investigations, not actually speaking to the patient and looking back at their history and trying to figure out what's going on. Family history and things like that are vitally important. As well, you find that if there's areas in the body that have inflammation or were previously scarred, that is where the dysregulated immunity tends to strike. And so you'll find patients with neuropathies that were settled for many years suddenly re-emerging, and the conventional treatments that we use don't work because it's an immune reset or an immune dysregulation with mast cell activation that tends to target scar tissue, that tends to target areas of inflammation in the body. So if there's pre-existing inflammation, those are going to be the sites where mast cells degranulate, and that's what triggers further inflammation. So each patient is very unique in that they have a specific set of symptoms that they present with. Doctors not looking into that are not going to understand it, and we're going to see a lot of patients struggling to recover. If you
Yeah.
do understand it and use the right treatment, you see the benefits in a few days. So it's simple for a patient, Philip. If you educate them in the right way, no matter their skepticism about him having picked up a COVID infection, or they look at us thinking, "Oh, you're always talking about COVID." But after 2 days of treatment, after being ill for 6 months and nobody could help them, after 2 days of treatment, you notice the recovery. Suddenly, you got faith in what's going on. And I think doctors need to understand that at the end of the day, whatever we do is to help patients.
One of the things that I think was critical, and I use it all the time talking to patients, is when you spoke about mast cell activation, antihistamines. I remember when I had my left Achilles tendon got inflamed, and it came out of the blue. I couldn't figure out what was going on. I was limping around, and I thought to myself, I can't think I had any new injury. So this may have been, like you said, scar tissue. If the principle is right and this is mast cell activation, an antihistamine will help. And there it did. And what you then starting to realize is that if people, especially the clinicians, if they are not aware of how this Omicron variant especially targets the mast cells and activates them in any area of inflammation, symptoms will make absolutely no sense. What are you finding in the real world when you find these patients with chronic symptoms? What do you see when they do the trial with antihistamines?
Philip, they have relatively quick recoveries. I think, Philip. Look, the presentations are wide and diverse. Like you said, scar tissue can be anywhere. It can suddenly trigger these wide, diverse effects in different people. Now, to just put some context, when you look at atopy, we tend to talk of sinusitis and asthma and things like that. But mast cells are the most abundant cell in your body, found in almost every tissue. So, if a mast cell degranulates in your heart, it's going to present as myocarditis. Now, where I showed that, Philip, in our previous discussions, I mentioned a sudden onset of psychosis in patients on the eighth day. Now, yes, I looked at that and I thought mast cell degranulation in the brain. And those patients, when put onto antihistamines, montelukast, basically clearing the chemo and cytokines that are released and resetting the immune response, they recovered within a day or two. My dad is a case in point. I had a few cousins that happened to. Now, how do you reverse psychosis using that kind of methodology? There's nothing in the literature that shows that psychosis has a basis in histamine release and mast cell degranulation. But then I guess with COVID, it's pushed us into directions we never thought we'd go into. And so, with the diversity of symptoms that we see, I'm looking for a common denominator on how to treat this. And in all that I've done over the past 5 years, the same simple basic methodology was to mop up chemokines and cytokines quickly and reset the immunity. Now, if you don't do that, it will spiral into a diversity of symptoms. So I'm mortified to think the number of patients that were diagnosed with psychotic illness and hospitalized for that when it was a simple mast cell dysregulation that could have been treated. And within a day or two, patient fully recovered. Now, I've seen that chronically with patients. Diverse symptoms that suddenly, with this methodology of treating, resetting the immune response back to its factory settings per se, they get immediate response and alleviation of symptoms in a very short space of time, be it vaccine injuries, be it long COVID patients or acute COVID patients presenting in that dysregulated phase. So the diversity of symptoms sometimes leads us into weird and wonderful diagnoses that don't look at the root cause of what's happening. The only thing that you got to look at in every patient, besides the immune dysregulation, is whether there is gut dysbiosis that can be suspected. And if that's not completely treated, then, well, like I said, the guy with the peanut allergy refusing to spit out the peanut. So we got to treat the gut and try and sort that out. And that tends to lead to long term recoveries.
I'll drop this in here a minute, which is that we've just put our not peer-reviewed paper up in the last few days about focusing on the macrophages in the long COVID pathophysiology. But as we go down, there is a whole section that I talk about with regards to the mast cells, and a lot of it, yeah, there it is, with mast cell activation as being central to I can't find it now, but I'll come back to it later. But mast cells as being absolutely central to an overlap between the macrophages and the mast cells. If the macrophages get activated, they then activate the mast cells. The mast cells then release the histamine. This drives the inflammation, and then you have this whole loop of continuous inflammation that can't stop until
Yeah.
you break it.
Yeah, Philip, remember a mast cell, if you look at mast cells in your body, as much as they're the most abundant type of cell in all the tissue, they tend to be immature. And they tend to only mature at the site of an insult. So they tend to mature dependent on the site that they arrive at. So it's like almost having your macrophages and monocytes and your all the other blood specific blood cells are the very specialist cells in your body. The mast cells are like the first responder, and they're a totipotent cell that can differentiate into anything. So a mast cell can become a macrophage, a mast cell can become a basophil, but it depends on the type of injury that it arrives at. And then, of course, the mast cell degranulation releases the chemokines and cytokines that call these other specialist cells to the site of injury. So the central role is the degranulation of the mast cell, drawing all these other cells to that site of injury. So when we go down and look at all the other differentiated cells that arrive there, it's past the injury itself. It's long past the initiation of that injury. So that's the reason I think when I treat using this methodology of mopping up all the chemokines and cytokines and simultaneously resetting the immunity, you get a quick benefit. Yes, the downstream issues that occur might take a few days to a week or two to start to settle down. But if you stop that central self perpetuating process, then everything else starts to find its way back.
And one thing I wanted to say,
That's a big
because
key to not seeing benefit.
I just wanted to highlight here, Shankara, because I'm seeing a lot of comments about antihistamine. Some people say they've tried them, they didn't work, and so on. This is not something, certainly your protocol is not something that they can easily replicate, because your protocol requires not just a simple antihistamine, but also either famotidine or cimetidine. It also involves montelukast, and it may involve steroids, all of which have to be prescribed by your doctor. You're not going to be able to do that. But for some people, who are having very minor symptoms that are more like an irritation, testing with an over-the-counter antihistamine to see if it helps is is pretty straightforward.
Yeah.
But getting a full therapy package without the doctor understanding all of these issues can be quite challenging.
Look, there's going to be re-emergence, Philip. Remember, it's a self-perpetuating process that we're dealing with. So you might have six different cytokines and chemokines that are being released. Those cause a dysregulation of your immunity. Your dysregulated immunity perpetuates those six. Now, if you mop up two, you get symptomatic relief. But as soon as you stop the treatment, it'll start up again because you still got other four there and they're dysregulating your immunity. And so the cycle will perpetuate itself. You're not going to get complete relief. The only way to actually abort the cycle is to mop up all the chemokines that you suspect in that particular patient that are being released and simultaneously reset the immune response with a course of steroids at the appropriate dose and to look at is there any persistence in the gut. If there is persistence in the gut, you're going to get the cycle start up again. So there's a lot of things that need to be done simultaneously to get good benefit that is persistent, prolonged benefit. Otherwise, you're going to get short relief from it, and as soon as you stop, everything comes back, or you're going to get partial relief. Certain areas that are affected might not see improvement from an antihistamine because it might not be histamine that is the big cytokine or chemokine that's actually triggering the process in that patient.
Now, one of the things I know you will know because you know Joachim and what he's been working on in the past in terms of ongoing presence of spike protein. And now this is so big, but so few people know about the fact that a lot of people, even if they have no symptoms, are probably still having issues around microclotting related to spike protein circulation, gut dysbiosis related to spike protein. Even when you stabilize the immune system, it hasn't gotten rid of the spike.
Yeah.
What do we do?
Yeah, that cohort, Philip, it initially was vaccinated that are constantly producing spike, but we're also seeing patients with repeated exposure to the new variants that are circulating that have spike protein. Now, I think with an infection, if you stop the immune dysregulation, I think your body has the ability, because the viral infection was mild, you don't have a high spike protein load, and so your body can heal from that relatively quickly. But in vaccinated patients, we've shown, I think the longest test done so far was 750 days odd counting, that you're still making spike protein. So there's a persistence of that spike protein. And of course, with the vaccine, the spike protein gets into tissues that the infection spike will not be able to get into. So when you're looking at that persistence in vaccinated patients, besides resetting the immunity, dealing with gut dysbiosis, mopping up cytokines, it's going to be a chronic process unless you detoxify the body from that spike protein and from the messenger RNA that's actually producing it. Now, walking with his work, the group of nutraceuticals that he's put together has shown great benefit in reducing spike protein levels, but also, we found that the mRNA causes cells to go into a senolytic or a senescent state. And so, the addition of xenomorphics and senolytics to try and destroy those cells that are actually spike is vitally important. So, there's a very complex mechanism underlying spike protein, its distribution via the vaccine to the various tissues, and how we're going to actually detoxify the body from this toxin. Uh, Spike protein has almost become an environmental toxin. We haven't addressed things like shedding and stuff like that. So, yeah, there's a lot of work to do, but downstream from my treatment, there's still a lot that needs to be done to maintain a patient in a state of remission.
So, practical question. Do you think that there is a cohort that is unfixable no matter what we do?
Look, I think so, Philip. There are certain patients where they're producing, especially those that are producing high levels of spike, but have severe reaction to it. Remember, it's a response to spike protein that causes a lot of the problem. So those patients that have severe responses to spike protein, we're going to have a lot of difficulty in trying to suppress them. So we're going to see, look, it's not going to get documented, but give it some time and you'll notice a decrease in lifespan. The average life expectancy is going to decrease with the population itself. Unfortunately, that's going to be a critical issue. But of course, Philip, I don't think it comes down to the length of your life, but more the quality of your life. And at the end of the day, no matter what the issue is, if we can find effective strategies and treatments to improve the quality of life of patients, that is good enough for now.
One of the biggies that is concerning me, and at the moment, I'll make it clear that I don't have strong evidence of it. It is more of a suspicion, and I don't know how it's going to be easy to exclude it, but it is linked to what they're finding with regards to the spike proteins being amyloid based, or the microclots being amyloid based. And I am almost expecting to find over time that amyloidosis, where deposition of amyloid in multiple tissues, heart, kidneys, brain, is happening as the body tries to cope with these kinds of exposures. Based on what I remember, we don't have any solutions for this.
Yeah, we don't, Philip, and we're seeing a surge in Alzheimer's, dementia, a lot of conditions that have amyloid as their basis, prion-like illnesses. So we're going to see those kind of things happen. I guess at the end of the day, the little that we can do, uh, look, there's a few things that can prevent that, not prevent it, but actually help negate symptoms. Melatonin is vitally important in brain health. Infrared, high infrared light to stimulate brain plasticity. There are certain sugars, trehalose being one of them, that tends to mop up amyloid kind of proteins. So yeah, these things haven't been proven, but I guess we're going to have to use everything in our armory. Unfortunately, you've got a pharmaceutical industry that wants to suppress all these kind of things, and unfortunately, we're going to have to go a bit back into medicine to look at the traditional ways that we treated patients, all the different systems of medicine, not only allopathy, if we're planning to actually resolve a lot of the issues. So I teach my patients to sun gaze. We found that some of the physiology that gets triggered is almost akin to hibernation in mammals. And so, besides treating the immune dysregulation, restoring the gut, those patients that have chronic fatigue, the mitochondrial dysfunction, you got to get them back into a natural state. Means resetting their diurnal cycles, getting in touch with nature, grounding, enough sleep. A bear doesn't just jump out of hibernation, it'll trigger a whole host of inflammatory processes. And so it's to slowly reintroduce them into, let's call it nature, the wild. And so I use those type of techniques to actually get patients to get back into things, restoring the gut microbiome, grounding, getting enough vitamin D, midday sunlight, having a midday nap. It's found to have great benefits to have a midday nap. So yeah, sun gazing in the morning, getting the infrared that's provided by the sun. So these are all methodologies that mainstream medicine doesn't even investigate. So we're going to have to go back in time before we can move into the future.
When we think about where we are now, we are, say, for 5 years down the line. The WHO has declared the pandemic is over, but the virus is still circulating. A lot of people are still saying, well, everybody looks okay. Yeah, there's some deaths, but it's nothing out of the ordinary. What, in your opinion, if there is no intervention, no mitigation, they don't listen to the questions, they don't do the research, they just let it run, what do you think it's going to look like?
Now, Philip, I think a large proportion of the population who is afflicted with wide and wonderful chronic illnesses that no one seems to understand is going to have their lifespan shortened. And over a period of time, we're going to see a population decrease. We've already seen an increase in the all-cause mortality. We've already seen a decrease in the birth rates around countries, and we're going to see shrinking populations. Yes, there'll be a cohort that remains unaffected that will survive this and still have their longevity, but that's until the next pandemic. So I think there's more that we need to do from the perspective of looking into biomedical research and how to actually regulate that, making sure that it's done ethically. There's a lot that can go wrong with where we've come from, and people don't realize that the frameworks are not in place. This is worse than nuclear technology. And so, yeah, from a governmental regulatory standpoint, the entire world is in a race with biotechnology. And we have absolutely no understanding of the outcomes and how disastrous they can be. So, yeah, at the end of the day, we're gonna see a lot of problems.
One of your concerns is around avian flu. We're hearing a lot. Again, there was a big pressure about we're going to have an influenza pandemic that had died down. But I've observed carefully, I've noticed that Japan had quite a severe outbreak of influenza A, nothing not different from what they'd had before. I think that's population immune suppression. It then was in Singapore, was then in the Philippines. The flu cases are rising in the UK. Any thoughts about what you think may be going on?
And look, Philip, it's a look. It makes the hair on the back of my neck stand up. We're seeing. Look, we can understand influenza circulating from the immune suppression that comes from vaccination. But when you talk of avian flu, it is almost extraordinary that we're going down the same road again. The similarities, before COVID, we had the Event 201, where they planned the public health responses to a coronavirus pandemic. Now we've had the same kind of event with an avian flu pandemic, and the same public health responses are being planned. Then, if you look at what's transpired over this time, we've culled birds, chicken. We've been discouraged from eating eggs. Yet, avian flu is limited to birds. You've got migratory birds, they're not being culled. So, this is not something, the culling is not something that's going to protect the birds. And it's not a virus that infects human beings. So, I don't see why we are also worried about picking up influenza virus. But there was an article that came out a few months ago from, I think, South Korea, where the virus, avian flu virus, was manipulated, and they managed to infect lab mice with it. Now, that's a gain of function where an avian virus is able to infect a mammal. Similar thing happened with coronavirus. A bat virus suddenly could infect human beings. Now, with that, it sounds very nefarious that now we have an avian flu virus that can infect mammals. And of course, we mammals. That was the preamble to what happened with the last pandemic. Now, suddenly, I see the world culling ostriches. Now, if you look at ostriches and where their benefit could come in, the ostrich itself, I don't see why they should cull it. It's not a bird of flight. So there's very little chance of it spreading it through the other populations of birds. Now, the beauty of ostriches, when you look at birds, they have a very similar immune response to pathogens like human beings do. They make immunoglobulin lambda. Their immunoglobulin is very similar to IgG and IgE in human beings. And like human beings, we transmit our immunity to the fetus through the placenta and through breast milk. But in birds, ostriches especially, they concentrate a lot of their antibodies in the yolk of their eggs. And so the yolk of the eggs have a very high density of antibodies. And if they have developed immunity to a avian flu virus, then their eggs provide a huge potential for the production of antibodies and the understanding of immune response. So I could understand why they're culling ostriches for no reason. There is a reason behind it. It will have great scientific significance if we have a pandemic where an avian flu or an avian flu virus was manipulated and now can infect mammals. The ostrich egg, with its high density of antibodies, can provide a very good treatment or prophylactic solution. Ostrich eggs, Philip, at the moment, they used to produce antibodies for different bacteria, Staphylococcus pneumoniae, certain other Staphylococcus aureus. But those antibodies are used in topical treatment of wounds. And it's found because of the antibody levels, they kill the bacteria in the wound. But because the egg is the proteins in the egg is very different from the human proteins, you don't have a reaction to it unless you're allergic to eggs. And of course, it works a lot better than steroids and things will do because it has no systemic side effects. Now, this kind of research has been going on for a long while, looking at the antibodies that are produced in the yolk of birds. And ostriches provide the greatest concentration of antibodies, and of course, have the biggest eggs. So, this kind of research can go further in giving us the antibodies we need in the event of an outbreak of a humanized avian influenza virus. So, yeah, the culling of the ostriches around the world seems very nefarious.
One of the big issues, and I'm trying my best not to get us in trouble here, um, but when you say that, I want the audience to understand something. Do not forget that we still don't know where this COVID virus came from. There is still an argument. If the White House think it came from a lab leak, some other scientists think that it was just an evolution naturally, but to have the furin cleavage site is a 1 in a trillion chance. But it raises again the issue of ethics. It raises the fact that if we haven't forced an answer on this issue, I think it does encourage people who may have been involved in gain of function research to think that they can get away with it again. I think that this is probably the greatest failure for the public. I'm not blaming scientists now. If you let somebody get away with something, you are giving them an opening to try it again, and the public has allowed politics and questions to be deflected and not asked the hard questions and insisted that the politicians come up with the right answers. Is that going to come back to bite us?
I think it will, Philip. I think it will. At the end of the day, if you're not contributing to the solution, I think there's a lot of controlled opposition that is dismissive of good science. So I don't see why people should be dismissive. It took us so long to understand long COVID, to acknowledge that long COVID exists. But long COVID patients know they got long COVID. They had problems. So if you don't have long COVID or you've never experienced it, why do you be dismissive of those that do? So if you don't have something to contribute, best remain silent. I think at the end of the day, those of us that are seeing things, that are understanding what's going on, should be given the chance to solve the problems. And of course, we've seen as well that people that were pro vaccine are now seeming to take the lead in trying to solve the problem. I think an apology is in order for those that push the vaccine and have seen patients injured from it, and then kindly step aside and let us do our work. Because at the end of the day, those that push the vaccine have lost the trust of the public. Why do you want to now be at the forefront of trying to find solutions? You shouldn't be there. Until you regain the trust of the public, kindly don't be dismissive and stand aside and let the people that are willing to put their lives on the line and actually look at these problems do their work unopposed by dismissive views.
Yeah, I think that's a very important point, Shankara, because in my view, after the COVID pandemic, expertise is not in a title. Expertise is in an outcome. And
Exactly.
if you can get people better, if you can identify problems, if you can find innovative solutions, you are the expert, not the title.
Yeah. I think the entirety of the way we look at medicine, Philip, needs to be reworked. The randomized double blind clinical trial has been proven to be blind, and it is limited by our power of observation. And of course, the eye doesn't see everything and the ear doesn't hear everything, and two people looking at the same thing
Are you
cannot
still
see the
there,
same.
Shankar? Yeah, I don't know if it was me or you that got lost a while ago.
Am I back, Philip?
Yes, 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 yes. You're
Yeah, I was
saying
saying,
about the randomized double blind,
yeah.
yes.
Yeah, the randomized double-blind clinical trial shouldn't be the gold standard of how we treat patients. That is for research. At the end of the day, A randomized double-blind clinical trial is based on observational skill. And our power of observation is limited by our senses. Two people looking at the same thing don't see the same thing. Two people hear the same thing and don't hear the same thing. So at the end of the day, we need to understand the limitations of what a randomized double-blind clinical trial can bring us. And we need to go back to patient-centered understanding of pathophysiology. A simple thing, Philip. Strangely, during the COVID pandemic, this controversy rose between germ and terrain theory and no such thing as viruses existing. But a virus is just a name. Uh, Exosomes get transmitted through the air constantly. Is a virus just a replicable, transmissible exosome called by a different name? Because it will do the same thing. So at the end of the day, these little controversies that show up and arguments on the side really don't help the patient in any way. We see things, we try and understand what's going on with the pathophysiology, and we try and improve the quality of life of patients. Bottom line. And anything that does that should be the gold standard.
Absolutely. I think that's captured it perfectly, Shankara. So as we close out, Shankara, so many people are lost. They no longer trust the system. They recognize that their clinicians don't understand what's going on with them or their loved ones. They oftentimes, we have what, 520 people on with us now, and so we appreciate them, but they have questions. They don't know where to go, what to do. They are in different parts of the world. What is the way forward, Shankar? What do you think is the best way that medicine can evolve to actually be at the point of need that patients require?
I think, Philip, the first thing we need to do is relieve it of its capture. So at the end of the day, the regulatory authorities that got a stronghold are basically captured through the pharmaceutical industry. And that is stifling the spreading of information to doctors that want to learn, that want to understand what's going on around them. Why are we being censored when we're getting good results? Now, yes, you can't save the world with these two hands. At the end of the day, those doctors that are willing, we're trying to educate them. But of course, we should be actually looking at medical training. So the new doctors that come out of medical school understand that we're dealing with a new set of physiology around the planet, and that needs to be understood. But you're never going to get into training programs in medical school. So we try to set up virtual platforms where doctors can understand this. We're trying to train doctors. I, on my website, shankaracheri.com, are now offering consultations. And I'm willing to have patients' GPs consult with them so that they can learn something and take it further and treat the next patient. We're going to have to try everything we can. We want to form a global private healers club so that we can operate and treat patients outside the framework of these regulatory authorities that are constantly stifling progress in the way we're treating this. So, yeah, there's a lot that needs to get done, but it's something that covers all facets from politics to economics to medicine to spirituality, and everything needs to be addressed.
And just before we close out, Shankar, I remembered that I had pulled up this medical mystery. And I think it's useful sometimes to talk through a real case, just so the audience understands. I came across this. They have a medical solution bounty where there are two patients that have certain conditions. And so we were going to just talk about one of them. We're not talking about the solution because I don't think they'd pay it out anyway. But anyway, so here is patient B. His main symptoms, I'll make this a little bit bigger, started 9/24. So this was about a year ago. Constant, dull, diffuse burning sensation, a few inches around the belly button, 100% of the waking time. Nausea that fluctuates throughout the day. It can be fairly intense, and it's unrelated to anything, time of day, posture, bowel movements, food, nothing at all. It's having suffering. So this is the example of somebody who is just suffering. They're only in, it's a male, in his 40s, normal weight, primarily vegetarian, doesn't smoke or drink, exercises 3 times a week, only had in his history sinus problems and generalized anxiety disorder. They have done every single test on him. His breath tests suggesting some gut dysbiosis were a bit high, but he didn't respond to antibiotics. Gallbladder scan was ejection fraction was a bit low. He has some mild chronic inflammation on his upper GI endoscopy. The stool testing, there is some inflammation, high zonulin, which fits and overgrowth of some of these bacteria. So he definitely has dysbiosis and monocytes of 11%. And then when you look at his blood tests, literally almost everything is normal except selenium and vitamin B6 a little bit high. He's supplementing. His monocytes are up 11%, and he has his HbA1c is slightly elevated. That's it. This is somebody who is struggling. This is not, and this is not unusual. And I can look at this case, and I said as soon as I read it, I said his problem is his sinuses and got dysbiosis. And if he doesn't fix that, he will never get better.
Yeah. Philip, it's it's a mast cell activation, right? It's a mast cell. He has a predisposition to atopy from his chronic history of sinusitis. From looking at his gut symptoms, they range all the way from the mouth to the anus. So it's not hyperacidity. It's not one single area that's being dysregulated. It's the entire gut. And when you have that entirety of the gut dysregulated, you're going to get dysbiosis as well. You're going to get leaky gut. That's going to create a whole lot of issues. If you look at his predisposition, he had chronic sinusitis, which shows mast cell issues. And one of the chemokines that cause problems is your serotonin. And he's got generalized anxiety disorder as one of his predispositions as well. And so, he's got a predisposition for mast cell dysregulation. Now, I would actually suggest the mast cell dysregulation is the primary cause of his gut dysbiosis or the gut issues that he has. Now, in treating him, you need to have the right antihistamines, leukotriene moppers, all those kind of things to take away all the chemokines that are there to allow his gut to heal. You also want to restore his gut microbiome, and you want to restore his gut health. So pre and probiotics, yes, a course of antibiotics, the appropriate ones, and a restart of the gut. But concurrently with that, he would need to have the right anti-chemokine, anti-cytokine measures. And you would also need the dysregulated immunity to be reset. And I can almost guarantee he'll have improvement in symptoms in a short space of time.
Absolutely. And for the chronic sinusitis, for those who know what I'm talking about, don't forget to hum. Humming heroes. It's in the description below. Increase the nitric oxide. Anti-inflammatory, antiviral, antibacterial. Simple stuff. Wonderful, Shankara, as usual. So thank you all, everyone who has been with us. We appreciate your support. Remember, is it shankarashetty.com?
Yeah, shankarashetty.com.
If you want to see what he's doing, please go there and take a look at that. So again, thank you everyone for being with us, and have a great evening. And Shankara, if you could just wait with me until after the outro. All right. Thank you all.